ordering a theatre list, I'm going to discuss today on how to order a theatre list in the NHS, so basically, most specifically, in an exam setting for the MRCS exam. So normally you'll be given a few cases with some clinical priority, and also on the other side you will have some comorbidities for each patient as well, and you need to prioritize based on the clinical urgency and the type of the operation that the patient needs and the comorbidities as well. So let's start by the first scenario, and then we're going to go through the rationale and the possible questions that you could be asked in this scenario. And then I know some people asked about this scenario for around 5 different patients with 5 different operations. I'm going to discuss this at the end, after explaining the rationale at the beginning. So, starting by a patient who has a strangulated hernia, COPD, and has pacemaker. The other one, diverticular disease, allergic to penicillin and iodine. The third one is knee replacement, and also this is insulin-dependent diabetes, and MRCS positive and atrial fibrillation. To be able to arrange these cases, to be able, they are already arranged, but to be able to reach a decision making on those 3 cases, we need to know a few things. Okay, so first of all, we have here a COPD patient, so we need to think what to consider in a patient with COPD. On the other side, we have a patient with pacemaker, and also what should you consider, what are the precautions to do before surgery, during and after surgery as well. With patients who are allergic to iodine and maybe antibiotic, and they will definitely need some antibiotic, what will be your precautions as well. On the other side, for elective cases that are MRCS positive, you need to be aware that MRCS usually will close the theater for deep cleaning as well. So let's start by what will be the preoperative preparation or the preoperative consideration that we need to consider. Okay. So I mean, this is just a few things when you are before you start any procedure, you need to do these few things. But here I'm just discussing the preoperative preparation. So when you have a diabetic patient, what will be your consideration for a diabetic patient? First of all, they need to be placed early on the list. You need to prioritize them. But on the other side, this is a comorbidity. So diabetic patient, if it's an elective and diabetic patient, they don't take a priority over an urgent patient. So let's say you have an incarcerated hernia who's not diabetic, and on the other side you have a total knee replacement who is diabetic. The incarcerated hernia will definitely take priority, and the diabetic patient can wait. You will not. It's not like an indication in itself to start the patient first on the list if they are diabetic. They need to be clinically urgent as well, according to the CPOD classification, which we're going to go to it. Well, so you need to put those patients early on the list because they have higher risk of having hypoglycemia, and this will allow early return to the normal glycemic control. The other side, for latex allergy. So in surgery, you're using lots of things that has latex in it. The latex usually has some powder in it, and this powder can be stuck with some of the instruments or the beds or even the environment of the operating theater. So basically, we need to give some deep cleaning to that area before for operating on a patient who has latex allergy. All right. So basically, these patients, you either start by them in the first day, or maybe keep them at the end after doing a deep cleaning. Like I said, it's not an indication for itself to start every patient with latex allergy to be the first on the list, but only if they are clinically urgent as well. So I'll give the same example. If you have a latex allergy patient who's maybe total knee replacement, and the other one is incarcerated hernia, completely septic, you would like to start with the incarcerated hernia over the latex allergy, and you can start by giving deep cleaning to theater, or maybe cancel the latex allergy and bring the patient the second day. So first on the list again, could be first on the list if they have latex allergy, and natural rubber allergies require clean theater at the time of the procedure. Okay. Well, the children as well need to be prioritized on the list, to be first on the list, all right? And the reason why they need to be prioritized is, that will give some reassurance to the family, and also will minimize the stress for the children. Once again, being a child is not an indication in itself to start by them. If you have a clinically unwell patient who's CPOD 1, you will operate on the CPOD 1 first. Okay? Local anesthetic, very quickly, we're going to go through this. So if you have a surgery that will be done under local anesthesia, it might be sensible to put it between major cases. So that will be some sort of a rest to our anesthetic colleagues. Major surgery. Major procedure should be considered early in the list because this might take longer time. And also, it's often best to put these cases first or early in the list because it can take longer and also it shouldn't be cancelled. MRSA, the methicillin resistant and C. diff. These patients can contaminate the theater, so that's why they need to be last on the list after doing all the surgery because the theater will need deep cleaning as well. What about clinical priority? So we talked about we're going to talk about the CPOD now, the clinical priority. So, like I said, there is big difference between emergency and elective cases and also the comorbidity. So we have many factors here. In this case, emergency, that takes a priority. So the clinical priority even takes more priority over being latex allergy or being an MRSA and so on. Cool. Going to NCPOD. So you have the classification here is divided into 4 things. It could be immediate and urgent, expedited, and elective. So immediate, this is life or limb saving. AAA, abdominal aortic aneurysm, and also patients with major trauma with neurovascular deficit or compartment syndrome as well, that will take a priority and will be number 1. So again, if you have a code 1 from the CPOD, and it doesn't really matter if the patient is diabetic or not diabetic, a child or not a child, this case will need to go within minutes. This case will need to go first on the list after making your decision. All right. So urgent cases, this is not life or limb saving, but it's life-threatening condition and might threaten the life within a few hours. Okay. So the decision need to be based. The patient need to be taken to theater within just an hour, up to an hour or hours from the decision making. 3, you have expedited cases. The patient is stable, requiring early intervention. This can be talking about the elective cancer treatment, patients with tendon repair, and the stable non-septic patients as well. Elective cases, this is elective. I'm sure you all know what it means, and that's it. Okay, so this is the National Confidential Inquiry into Patient Outcome and Death, or NCPOD. All right, so let's ask a few questions here before moving on to our next step. All right, so we have what is the type of anesthesia on each case on the list. If we go back, so that was our list. Let me find out. So that was our list. So for strangulated hernia, patient is COPD and have pacemaker as well. So we need to think that being in COPD, general anesthesia might increase the risk of having atelectasis, pneumonia, and the exacerbation of COPD. So always consider local and regional anesthesia for them. For diverticular abscess, patient is allergic. It didn't mention any other comorbidities. So as long as there is no contraindication for having general anesthesia, we can give general anesthesia for this patient. The total knee replacement, on the last case, we can always consider general anesthesia for them, or even regional or spinal anesthesia. So, we're going to move here the type of anesthesia for each case. So in inguinal hernia, you can consider regional anesthesia, and others you can consider general anesthesia for them. Yeah. Okay. Just checking one thing, but that's right. What are the current guidelines for perioperative glycemic control in diabetic patients? As we explained, the patient that doesn't want to come one day before the surgery if it's elective. It needs to be prioritized first on the list. The patient needs only to miss single dose or single meal of their usual daily meals. If you're gonna keep them fasting for a long time, give variable rate insulin for them. The ideal fluid for them is 0.45 NaCl or normal saline with KCl as well. All right, that's the ideal saline. And also keep monitoring blood glucose and measure it before the surgery, during and after the surgery as well. After the surgery, get the diabetic team to review them. So as you can see here, prioritize first in the list. Not necessary to bring them in. There's no more one missed meal. Analgesia and antiemetic medication to be given. I didn't mention that. Start their insulin as well as soon as they are able to swallow or eat and drink after the surgery. So this, as you can see here, these are the consideration for patients with diabetes who are undergoing surgery. Okay. Precautions should be taken in patients with pacemaker. They will need pre-operatively and intraoperatively a few changes or modification in their environment. So pre-operatively, all right, pre-operatively, the patient should undergo pacemaker check to make sure that we have the direct measurement for that pacemaker. And also they should have a recent review in their pacemaker in clinic and follow-up clinic as well, just before going to surgery. Intraoperatively, we need to think about whether we're going to use monopolar or bipolar. And thinking about this, the bipolar is better than using the monopolar for those patients. Okay. We also need to be aware that this patient can get cardiac arrest at any moment. We need to be ready for that. And the patient should be monitored by ECG all the time. The difference between bipolar and monopolar. So monopolar diathermy, from its name, it just has one pole. And this is active electrode. The electricity or the current passes directly to the tissue. All right, directly to the tissue. And basically takes larger surface area as well. And the bipolar diathermy on the other side, basically have two tips. In between them, the current will pass, and it's a slightly smaller surface area than the monopolar diathermy. The factor to consider when placing a diathermy pad in patients with a pacemaker, again, as close to the operative site as possible, all right, so the ground plate, and also it must not be placed on any bony prominence, metal prosthesis, or distal to a tourniquet, and so on. The complications with patients with COPD at risk of, they might have atelectasis, pneumonia, and even pulmonary embolism and exacerbation of COPD. How can we reduce this? As much as possible, try to avoid using general anesthesia for them. Maybe use local or regional anesthesia. Minimize the time of the procedure. Get a pre-operative and post-operative physiotherapy to review them, and also consider GP review before the surgery, and consider a smoking cessation before the surgery as well. Okay, I have a few more questions. How would you manage warfarin in patients? So warfarin, ideally, you should follow your local guidelines. It might be different from a hospital to another. Warfarin should be stopped at least 4 days before the surgery, and both the patient low molecular weight heparin, which can be stopped 6 hours before, 12 hours before the surgery, and you can restart warfarin as soon as the patient is able to eat and drink after the surgery, and there is no contraindication for it. All right. Of course, we need to do assessment to the patient current risks and benefits, and do official VTE assessment. All right. So we have low risk, stop warfarin 5 days. High risk, you can stop 4 days before the surgery, restart low molecular weight heparin, and so on. Okay. What to use in case of iodine allergy? In this one, we usually use chlorhexidine based on the antiseptic instead. And also, which antiseptic will be used in patients with MRCS? So would be based on the hospital protocol, but chlorhexidine will usually be used. Prophylactic antibiotic and penicillin allergy, you'll follow the local guidelines, but vancomycin and cefazolin can be used. The colostomy preparation very quickly. I mean, just see that, you can read it very quickly. And antiseptic for skin preparation, you can just read it very quickly as well. So now we covered the important areas, which include, we need to think when we have a patient who might be going to surgery, we need to think, are they urgent or not? What is their CPOT status? Are they elective or immediate or urgent, or they can wait for a bit. That's the first thing you think of. The second thing you can think of is whether this patient has any comorbidity or contraindication or any certain arrangement in theater. Well, before we move into the cases and start arranging the theater list, we also need to consider including the team with us before making a decision. So I believe you're not expected to make the decision on your own as a junior doctor or as someone who is finishing the MRCS. You need to consider the opinion of the anesthetic team with you. You need to consider the opinion of the pre and post-operative ITU team as well, whether an ITU bed is available or not. We need to consider how many theater that you have. You need to include the theater team with you. Get a theater coordinator to speak with you before preparing anything really. Also, you need to consider the opinion of your senior. So what usually happens is you will have a meeting in the morning where the handover happens, and it will tell you on theater list we have this patient, and this patient, and so on. And after that, we'll go to a team brief in the theater, and the team brief will include basically everyone, the surgeon and the assistant, the theater team, including the theater coordinator, and also the anesthetic team as well. And we're going to discuss everything in detail, and we'll see, well, that case goes first, and then that case goes second, and the anesthetist can say their opinion, and the surgeon will say their opinion as well, and they will take it from there. So in an exam setting, of course, you're expected to say the key words in each thing. You need to say that diabetes needs to be prioritized, and then this needs to be prioritized for this reason, and so on. Okay, so I'm going to go back to explain all of this to that scenario that was sent to me by one of our colleagues. So we have, as you can see here, first thing I'm going to look at the patient details. What I'm concerned about is the age. So I can see all of them are above than 50 years at least. Maybe this one a little bit younger, but all of them are quite old enough, and they are not sort of child. We don't have any child in here. Second thing is, my thinking will be looking at the theater or the operation itself. As I can see here, I have a very urgent, potentially unwell patient, the Hartmann procedure for perforation, another very urgent, potentially unwell patient, another septic joint. You can think that tenosynovitis needs washout, and a third one with an incision drainage of a tonsillar abscess. Okay. So my thinking about this, so I have 3 patients, 1, 2, 3, with possible compromise, and an infected or a septic joint, and also you have here an elective case. So that's my first thing I'll think about. Next, I'll think about the comorbidities. I'll start choosing between the cases. Okay, so let's say now I'm going to answer in an exam. So I'm going to say, looking at the theater list, I'm going to summarize the main issues. The first patient is a major surgery that might take longer time, and the patient needs to be clinically prioritized. However, they are an orphan, and they might need optimization, and also they might need certain preparation in theater or reversal to this orphan. I would like to get more information about this and about the orphan status for them. We have also another urgent case with potentially incarcerated hernia, and they are diabetic, and this means they need to be prioritized as first on the list. But that will not be my final decision. I'll continue analyzing the cases. We have a washout who's allergic to penicillin and iodine, but of course we can sort the penicillin allergy by giving another medication, and the iodine by using chlorhexidine. The last one, which I'm very concerned about, is incision and drainage of tonsillar abscess and MRCS positive. I have here 2 issues. First of all, I need to know more about their airway status and whether their airway is affected or not. And second of all, I need to be aware that they are MRCS positive, and that means we might need to close the theater if we took them first. So I need to gather more information about the patient, and also I need to speak with my theater team, because I can see here we have 5 important cases. At least 4 of them need to be operated on today. I need to check how many theater do we have today. Is it just 1 theater? And if there is only 1 theater, I'll speak with the theater coordinator to get an extra theater for us, because sometimes in this case, we potentially need to operate in 2 patients at the same time. I'll also need to get the anesthetic team involved in the decision making, because their assessment to the first and second and the last patient will be extremely important, and they can help us to decide which one is clinically more urgent as well. I will also include my senior or my consultant in the decision making before moving forward. So my opinion will be, if the patient with the tonsillar abscess, if the airway is compromised, I'll put them first on the list, but I need to be aware that this needs to be an extra theater and not the main theater that I have, because that will definitely close a theater for me. If the airway is patent and secure, I'll keep this patient in a monitored area, because compromise of the airway might happen at any time, and then I'll consider taking them to theater as the last patient on the list if the airway is secure. My second case I'll be thinking one of 2 options, whether the Hartmann procedure or the incarcerated hernia. I'll need to go and assess both patients and take their news score and check the patient warfarin status and also the other patient diabetic control. First of all, the patient with perforation and having perforated cancer might be more clinically urgent than the incarcerated femoral hernia. However, if the warfarin is not yet reversed and there'll be higher risk of bleeding, they can wait and there'll be the second case. So one could be the first or the second case based on the warfarin status. On the other side, for the incarcerated hernia, is still clinically more important, and they have diabetes, and I might consider them the first on the list because they are diabetic, and if I only have one theater, I'll keep them the second on the list after the incarcerated hernia. The ideal scenario will be that the patient the tonsillar abscess patient, airway is patent and secure, and I had availability of 2 theaters at the same time. However, if my last option that I have just single theater available for all these patients, I will consider taking the Hartmann procedure first if the risk of bleeding is low, and the incarcerated femoral hernia next if they are clinically stable, and the washout will be last case on the list. The tenous will be the next case, not the last case, and the tonsillar abscess will be the last case if their airway is patent and secure. The total knee replacement or COPD need further assessment. It's an elective case, so it can wait or can even be cancelled if we did not have time in theatre. Of course, I can see all these patients from different specialties, so we'll need different consultants to be involved in the decision making, including general surgery consultant and also orthopedic and trauma consultant and ENT consultant as well. And hopefully we'll have more than one single theater available. So that's my opinion and my analysis and assessment for all these cases. In an exam setting, in my opinion, it's very unlikely that you will get a case like that includes many different types of teams need to be involved in the decision making, and they're just asking an SHO or a junior doctor to make a decision about this. You will definitely need support from different teams and different seniors and the theater coordinator. Like I said, in this one, the main assessment is about your decision making process and not just giving a list. If you're asking me now that if you want to give a list on what to do, which one is first, which one is second, assuming that the patient was a tonsillar abscess, patent and secure, and we only have single theater, which is very unlikely because it doesn't make any sense that you have general surgery and orthopedic and also ENT in the same theater. That would be very less likely in a very small hospital. That I think it doesn't really happen. Okay, so usually we'll have a dedicated theater for each team separately. But if you're asking me in that imaginary scenario that will have a single theater for 3 different teams, I will definitely put the abscess first if their airway is compromised, and last if their airway is not compromised. Okay, because even if you're gonna say, well, you're gonna close a theater for this patient, if we didn't, likely this patient might die, and he is the youngest patient as well, despite the age should not be really a factor. And if I did that and I have a single theater, I will definitely call another hospital for sending other patients to them, because I don't have the capacity to accept 5 urgent patients, if I have single theater in that imaginary scenario. Okay? So this is just an assessment, and also if the patient airway is patent and secure, I'll keep them in a monitored area. I'll start with the Hartmann. Next will be the incarcerated hernia, and I'll keep the incarcerated hernia on variable rate insulin. And third will be the washout of tenosynovitis. Okay. Thank you. That's my opinion about this case, and it's been discussed with one of my seniors, and they agree as well. But that's not a right scenario, in my opinion. It's not written in a right way. If you ask me to rewrite it, I'm gonna give you the Hartmann and incarcerated hernia, and maybe add one of the more general surgery operations, or maybe total knee replacement with COPD. But I'm not gonna make it very complex and irrational, and doesn't make sense. Because it doesn't make sense to have patients from different teams and expecting a single person to make a decision. All right, thank you everyone. That is my assessment to it.